Assalamu alaikum. How are you, everybody? I hope you keep safe in this horrible pandemic we're suffering from. Actually, I'm sure everybody's heart is broken, but this is life. Will come and go, and life will continue. Applied transplant immunology. This has been agreed with Professor Hussein Chaisha to be presented on the 5th of November. And we agreed together that we will address the unknown, we'll address the unusual, we'll discuss what you don't know and what we don't know. It's better to know what we don't know in order to know. Disclaimer, I don't claim and I will never claim that I'm experienced in transplant immunology. I try to get an explanation for any immunological challenges I face in my practice. Everybody knows, and I'm sure, that what we know is very little. We don't know a lot, but we'll keep trying and we'll keep learning. As Professor Ayman mentioned earlier on at the introduction, it's a huge topic. We address the unknown and the unusual, maybe the forgotten as well. So the objectives of these two talks, I'm going to give part one today, is to discuss the relevance of broad and split HLA antigens, epitopes and ablets, unacceptable antigens, mean fluorescence intensity, MFI, cross-match techniques, CPRA and PRA, briefly touches on HLA typing, relative mean fluorescence, what does it mean? The difference between lymphocyte we use in CDC and the kidney tissues. At the end, we're going to discuss what would we do with HLA antigens. The topics of these two lectures is not just from books. It's basically focused on what we do in Sheffield. You discovered that different practices everywhere. Remember, one size does not fit all. It depends on the resources, it depends on the catchment population, the genetic makeup of the people you treat, experience, climate, environment, education, everything. What's applicable in Nigeria is not applicable in the States. What's applicable in the States, not applicable in Nigeria. What's applicable in UK is not applicable in the States. Remember, one size does not fit all. Part two is more detailed and more clinically orientated about the preformed DSAs, de novo DSAs, and non-DSAs. The DSA and C4D deposition, non-HLA antibodies, and case discussion. We'll give clinical scenarios were managed and treated in Sheffield and presenting the outcomes, good and bad. The first topic is broad and split HLA antigens. Why should we bother about broad and split HLA antigens? And what's broad, what's split? In reality, because of the advancement in HLA typing, we discovered that the HLA typing we know consisted from many groups, subgroups, subtypes, split. For example, HLA 9 is split into HLA 23 and 24. And if you look at the bottom of the slide, it is just a sample. HLA A10 is divided into A25, A26, A34, A66. You will never remember all these splits and broad, but we have tables to look at. And the way it's written on the cross-match is quite confusing because they will write the split first and the broad between brackets. Are they important? Why should we make a fuss about it? Actually, it's an old study by Oplitz, published in the Lancet, 1988, showed significant difference when you match for the split compared to the broad. In his study, which published decades ago, showed that if you analyze the survival based on the split, you can discover that the survival is quite significantly different if you match for the split compared to the broad. So 31% difference when you match for the split, when you compare the split, and only 6% when you match for broad. So it's important, in spite of the split share many characteristics, but immunologically are different. Subsequently, the outcome will be different. So this is why it's important to know the split and the broad and match for the split. In UK, for the last 10 years, we match for the split. And exactly we write the broad, for our knowledge, sometimes, not all the time, between brackets. Fine, let's move to the next one. Epitope and applet. You can see on the slide, this is antibody, and this is antigen. When the antibody interacts with an antigen, it interacts only with part of the antigen called epitope. So the epitope is, for our general colleagues, is the antigen binding site. Great. What's applet? Actually, applet is a functional antigen binding site. You discover that the antibody only binds to 2, 3 to 4 amino acids of this epitope, not the whole epitope. So the matching even didn't restrict itself to the broad and split. No, it went further deeper into the epitope and applet. Is it for the sake of presentations, or sake of paper, or was it more clinically relevant, clinically important? I will explain this in the next few slides. As I mentioned, the applet is the functional epitope. There are 2 to 3 amino acids recognized by the HLA antibody. among the whole epitope. Okay. Private epitope and public epitope. Now we are getting into a deep water. We discover that half of class 1, HLA class 1, have private epitopes. For your knowledge, HLA has 5 or 6, 7, 8, 9 epitopes. Whatever number they have. The private epitope, which is a specific epitope not shared by other HLA antigens. So if you got sensitization against this epitope, you get antibody against this epitope only. So again, this HLA antigen only. Okay, it is a problem, but this problem is worse, what's called the public epitope, when different HLA antigens share the same epitope. This means if you have antibody against one of these epitopes, many HLA antigens become unacceptable HLA antigens. Let me explain further. If you look here, because of the public epitopes, individuals sensitized against HLA-A2 develop antibody, which will react with HLA-A2, A23, A24, A68, A69, A57, A58, God only knows how many other HLA antigens will react with. So in terms of sensitization, you have to know the specificity and be aware of what's called CREGs, cross-reactive groups. A2, A23, A24, A68, A69, A57, A58, called CREGs groups. We have lists of these CREGs. You don't need even to memorize them. It's quite difficult. Moreover, or make it more complicated, sometimes you get antibody after a sensitizing event in the absence of the HLA antigen. Let's just say you get antibody A3 DSA, but the donor hasn't got HLA A3. What happened? This is because of the CREGs, because they share the epitopes. And this is important when you look at highly sensitized patients. Of course, the situation now is different. Patients, survive longer compared to the past. When they get transplanted, you could have 1, 2, 3, even 4 transplants. You might get blood transfusion. Ladies get pregnant, or any other sensitizing events. You discover that I would say equal 50% of our patients on the waiting list are sensitized. So understanding the epitopes and the cross-reactive groups is important, because this is what you are dealing with day and night. Unless you stop transplanting them, of course, sensitized patient is not a contraindication for transplantation, but you have to use different techniques to transplant them, different immunosuppression, different protocol, different approach. Fine. So what is the relevance of epitope matching? I can summarize it into few words. The more epitope mismatches you have, the more DSAs we have. More acute rejection. Subsequently, transplant glomerulopathy. If you have more epitopal mismatches with a failed graft, the chances of a second graft becomes less. But the problem when I discussed with our immunology lab regarding the epitopal matching, of course, they need high resolution typing, 4 digits, rather than 2 digits, which it is a standard, you know, in UK. Cost, more expensive, of course. Again, what's the cutoff? 22 epitopes mismatch, 15, 13, no consensus, no agreement. Like everything in medicine, one center do X, another center do Y. What techniques we need to use to identify these epitopes? Loads of techniques, different sensitivities, different specificities. This is why it's not widely applicable on a national base, individualized based on each center. Nothing is wrong, nothing is right, till we get agreement. Also, the policies could change because of the catchment population. In London, many Asians, many African, many Arabs, many ethnic minorities, of course, the demography of catchment population is different from Aberdeen, more white. The real application of epitope matching is coming from the Eurotransplant, where we use it routinely and clearly to determine the unacceptable and acceptable antigens in the Eurotransplant program. We use it in Sheffield on retransplantation. Edward suggested before planning immunosuppression, minimization, or withdrawal, basically as a risk stratification. Whether this will be implemented or not, this is another issue. Fine, let's move to the next. Unacceptable antigens. It's important when you put the patient on the waiting list to report the unacceptable antigens, especially if you have a deceased donor program, cadaveric program, or the paired exchange scheme. This is important, of course, for sensitized patients. In the first place, to avoid offering them a particular kidney. Subsequently, avoiding positive cross-match. Also, it shortens the cold ischemia time. But how the centers define unacceptable antigens, again, is like how long a piece of string. Everyone does his own things, but all of them agree on the same principle. Other use complement-dependent cytotoxicity, CDC-assay, or in Sheffield we use flow cytometry, but without C1Q assay. Just to remind you, C1Q assay is to determine whether the DSA is complement fixing or complement not fixing. We'll discuss this actually in detail in part 2. If you're using the flow cytometry for cross-matching, of course, you'll be aware of the MFI, mean fluorescence intensity. I'm defining this now because I'm going to talk about it later on when I discuss the clinical scenarios and the cases we transplanted in Sheffield. The definition is easily explained. It's the mean intensity of antibody expression on flow cytometry. It's a semi-quantitative measures of DCA level. It's a guide, but it's not totally quantitative because you're not counting the number of antibodies. You're looking at the intensity of the flow cytometry of the dye, the fluorescence. Again, different cutoff in different laboratories. And this is why when we deal with, let us say, Liverpool or somewhere else, we need to know the cutoff, What about the strength of DSA, the MFI level? Should the high MFI preclude transplantation? Nothing should preclude transplantation. In reality, higher MFI associated with higher risk of rejection. In fact, there is poor correlation, little correlation between DSA strength and the clinical outcome. There's no consistency. A lot of us are aware that many transplants were successful in spite of high MFI, high antibody level. I mean successful, I don't mean they didn't have rejection. Why this discrepancy between the DCA level, which is reflected by the MFI, and the reality, the rejection, the outcome? Remember, if you use flow cytometer, the flow cytometry is the beads are loaded with HLA antigens. Standard loading, standard concentration. But we take it as a surrogate marker of the kidney. But the kidney does not express the HLA antigen in the same intensity like what we did with the beads used for flow cytometry. If you use CDC cross-match, again, we use lymphocytes. we see the cytotoxicity again in these lymphocytes. These lymphocytes behave differently from the kidney. And this is quite apparent when you deal with class 2. As I'm going to explain on the cases we did and published in part 2, class 2, HLA, DR, DP, DQ, are not well expressed on the kidney, especially the DP and DQ, but well expressed on the lymphocyte. So you got positive CDC cross-match due to class 2 antibodies, but when you put the kidney in, you won't get rejection because the antigen may not be there. So the antibody without antigen will cause acute rejection, will damage the kidney. It can cause chronic damage later on, but none of these kidneys will live forever. Again, what's a cutoff of what's called dangerous high level of MFI? No standardization, no normalization. And if you look at the flow cytometric cross-match, each center has a cutoff of intensity of flow cytometry, the intensity of MFI. Of course, after defining the antibody specificity. Some centers consider MFI of 1,000 is positive, other 10,000 is positive. In Sheffield here is a big immunology lab, actually a center immunology lab, and there is another one in Liverpool. My colleague, Professor Sharma, already on the call, and he works in Liverpool. And we have different cutoff level. We have cutoff 2,000 for class 1, DSA, and 5,000 for class 2. In Liverpool, we have 3,000 for class 1 and 7,500 for class 2. And this is what's called clinically significant MFI. So it's local again. Remember, one size does not fit all. Fine. I will come to the PRA and CPRA. If you look at the principle of how we measure the PRA, you put the serum with the lymphocyte panel from a local donor, from local donors. The panel ranges between 20 and 100. And you see, you add complement, of course, rapid complement and vital dye, and you see the reaction. This was called CDC, complement dependent cytotoxicity. Cell lysis is examined under inverted phase macroscopy. Percentage of reaction reported as PRA. Is it accurate? Is it reliable? Let us see. The PRA of patients will change. Don't forget the antibody level waxes and wanes, goes up and down. Or, which is more important here, the change in the composition of the HLA or the lymphocyte, the source of lymphocyte you used. So the panel I'm using today, if I got different panel, I got different percentage. Why? Because the number of the source coming from 20 to 100 donors, small number. One of the main problem is not consistent, is not comparable between laboratories because of the difference in composition of cell panel. To be honest, you know, if the cross match is negative, PRA does not mean anything. What we need is to augment immunosuppression. This shouldn't preclude transplantation. What about the CPRA? Calculated panel reactive antibodies. In UK, we call it calculated reaction frequency. The panel here is different in number, 10,000 to 12,000 potential donors. So more accurate, more specific. However, nothing called perfect science. We don't check HLA, CW, DP, or DQ because they are not commonly typed. But at least we will give you more accurate estimate of the sensitization and the potential transplantability of this patient compared to PRA. I've written the techniques, either serological or solid phase assay, ELISA, the problem with ELISA variation between kits, or flow cytometry uses the microbeads, but the standard is Luminex single antigen beads, commonly used. And this is actually a brief summary of the CDC and flow cytometry in terms of cross-match. You see here, the cost is high with flow cytometry, is more sensitive, actually oversensitive. It does not depend on cells, but if you have dead cells, it won't give you accurate results. You cannot quantify with the CDC, but you could quantify with the flow cytometry. We know that IgM can cause headache with the CDC. Actually, IgM is never measured by the flow cytometry. Detects complement fixing because you use complement, but we don't use complement here. This is why it does not detect complement fixing. So nothing is perfect. Non-HLA antibodies, which is quite common. Yes, detected with CDC. Not routinely detected by flow cytometry, but we know, we'll see the signs of non-HLA antibodies. When you have positive cross-match with no DSA, this is definitely non-HLA antibodies. Fine. Virtual cross-match. Because of the flow cytometry and the proper, 4-digit typing of HLA, we can do what's called virtual cross-match. Virtual cross-match is not a real cross-match in the sense you have antigen beads or lymphocytes and you just the reactions, antibodies. No, it is just a paper cross-match. You know the HLA specificity of these DSA antibodies, and you know 4-digit HLA typing, and you compare both of them together on a piece of paper. And this will tell you the actual cross-match will be positive or negative. I wouldn't go into the details of versus cross-match. Again, is an imperfect science, because again, you know, the non-conformant fixing could be contributing, levels of DSAs, you know, could be a low level to cause damage. But anyway, this is not, you know, our scope today. Fine. Rare HLA antigens. What would you do with them? The world now is a big village. You will find actually different race everywhere. In Germany, you find the Black, Arab, Asians, and all of them are German. In Britain, the same. It's cosmopolitan. We know all the Americans are ethnic minority. In Africa, we'll see white African, Asian African. The problem with this mixed race, because they came from ethnic minority, they don't constitute the major bulk of the population. You will get HLA, rare HLA antigens. If your allocation is based on HLA, this will exclude these people. They will never get a kidney. So we have to do something about it. Digging into the depth of HLA and the specificity of the antigens itself. What we do is default when we identify a rare HLA antigen. By the way, it's a population specific. The rare antigen here in the UK is different from Japan, from Egypt, from Nigeria, from Pakistan. But they have to be identified. We identify them and default them to the nearest HLA antigen to allow transplantability with minimal risk. Because we have loads, hundreds of HLA antigens. The difference between them could be minor. So we default them to the nearest one. And I will give you an example shortly. This is UK list. This is part of the list, by the way. And on the left-hand side, our list of rare HLA antigens. A36, this is common in Africa, very rare in UK. B53 is common in Southeast Asia, Japan, China, part of China, Korea. And I would like you to have a look at this. Remember, because there is a clinical scenario coming related to these two things, two types. So the B48, HLA B48 is closely related. It's not similar, but nearly similar to B40. So this is the cross-match and tissue typing of one of our patients, which we will discuss in part 2. Look at the typing at the top. It will tell you straight away it's 2-2-2 mismatch. So the likelihood, and we know he's from ethnic minority, he's an Asian guy. We know that if we kept him like this, he will never get a kidney or die on dialysis. Can we default any rare antigen he has to make the match look better? Basically, to try to deceive the computer, because the allocation is computer-based. If you look at the box at the bottom, HLA-B, DR mismatch, 1-2-1 broad. Split 2-2-2. Because the standard here in UK is the split. It would be difficult to get a kidney, especially it's highly sensitized as well. And we'll discuss this later, this part of the story. But defaulted. Why? He has a real HLA antigen. Remember the B48 defaulted, treated as considered as B40. All right. Okay, this does not explain the whole picture. What's happening here? This explains only part of the story, because it has split as well. The DR14 and DR13 are split of DR6. So I turn my eye blind and accept the kidney for him, but I'm aware that he's full house mismatch. And this is how I can overcome the problem of keeping him on the waiting list. You know, these days, there is no, the weight on the matching is not that strong as used to be in the past. Many other factors are contributing: sensitization, age, whether it's a child or adult, also the waiting time, which comes first. Because of the advancement in immunosuppression, we can bridge this terrible HLA matching. Fine. I will save your eyes and look at this. Antibody delisted patient, and HLA-A2 has previously been listed as unacceptable antigen. This guy would have a problem unless we do this, because HLA-A2 is the common HLA in European, counts for 50% of the population are A2, HLA-A2. Means I'm excluding 50% of the donors for matching with him. But what delisting means? Actually, myself and my nephrology colleague, an immunologist, looked at his DCA level, because as well, if it's highly sensitized, all these DCA will be considered unacceptable antigens. But are they clinically significant or not? Remember, the computer does not think. You feed him with the information, give you an answer without justification, matches word for word, number for number. So delisted means we excluded all the low risk antibodies, all the levels below 2,000 for class 1 and 5,000 for class 2 being excluded. We didn't notify, we didn't feed it into the system. We kept it locally here in order to get him a kidney. But we are aware he's highly sensitized. On our waiting list is highly sensitized, and the CRF or the CPRA for this patient was 100%. Came down after all this effort to 93%. Subsequently, he got an offer and we transplanted him. Fine. We're talking about highly sensitized patients, donor-specific antibodies. And we said is a relative, is not an absolute contraindication to transplant patients with high DSA. Not that. Is not absolute contraindication as well to transplant patient with positive cross-match. But the word positive cross-match is like how long a piece of string. Could be strongly positive, could be weakly positive. What tells me what's strong and what's weak? We need some guidance. And this is actually the value of, if you're transplanting against positive cross-match or highly sensitized patient with weird cross-match, abnormal cross-match, you need to know what's called relative mean fluorescence. Simply is how positive is positive, the degree of positivity and degree of negativities. So this is being compared against control and a cutoff. I don't know the technique, honestly, how they do it, but always asking for this number to know, is it borderline positive or strongly positive? So the cutoff in our center for positive T-cell cross-match is 1.48. And for B-cell positive cross-match is 1.88. If it's just above the cutoff, means is borderline positive. Of course, we have to think, is it class 1 or class 2, because both are different in terms of management. But this will be discussed in part 2. But I will repeat this cutoff again when we come to the clinical scenarios. Fine, lymphocyte versus kidney tissues. For centers that use CDC cross-match, is lymphotoxicity, isn't it? Use lymphocytes. Lymphocytes taken as surrogate marker of the kidney, but they are not kidney tissues. Kidney tissues have different expression of HLA, especially class 2, DR, DQ, DP. Actually, mainly DP and DQ with less but definite variability in DR. Knowing this, it will give you room for maneuver that you're dealing, that positive cross-match is not consistent, not always consistent with acute rejection, whether hyperacute or acute. Of course, highly sensitized patients, we have reduced graft survival compared to non-sensitized patients. But still, you transplant them. You give them 5-6 years out of this kidney of dialysis with new normalization, with better quality of life, better than keep them rotten on dialysis. Thank you.
Okay.
Thank you very much, Professor Halawa. It was a very elegant tour in the different definitions, which you made them very easy, although they are a very complicated subject. Thank you very, very much.
Yeah, pleasure.
I think there are many questions from the audience before we go to other discussions. Could I start by you mentioned in the applet matching that there is no cutoff in different parameters, but are there any acceptable ranges that you use, for example, in the European, different from the American regarding the cutoff of the applets?
No, I mean, I discussed it with our tissue typing lab. They don't, they don't have any consensus. And even there is no UK guidelines to suggest the cutoff. And this is why it's not widely universal, widely acceptable. You do it, or sometimes they don't do it because, we don't know. Is it, of course, but there is one sure, thing, which is the more the mismatches, you're more likely to have problems, immunological, damage to the kidney. So the less mismatches, the better. But again, this is how long piece of string, what they mean by more, what they mean by less. There is no agreement at all. They may agree.
Also, you mentioned that the virtual cross match is not very important.
Important. No. It's important, but it's not the scope for discussion today. Virtual match, we do it here in Sheffield, and in UK actually will be done. And this is important for cadaveric and deceased donor transplantation because this will shorten the cold ischemia time. We know even beforehand when we get a kidney offer, we discuss with the tissue typing lab, and they review the patient, detailed tissue typing, and they review the potential donor history and sensitization, all sorts of things. And then they tell us, yes, you can go virtually. It is a cross match, but on paper rather than using cells or lab techniques.
Do you think with the strong immunosuppressive or desensitization protocols that are applied, for example, when we make transplant across ABO incompatibility, do we need to go in all these detailed tests, or we can just do, I mean, if you want to select some of these tests that you mentioned for clinical, you mentioned around 10 points. We need to do all of them. You told that the cost is very high. What do you think is the priority for to be used whenever we want to transplant a highly sensitive patient, for example?
Fine. Prof. Hani, you opened the floodgate now on me, because APO incompatible, again, APO incompatible is different because you could be APO, I'm talking about HLA incompatible. But the worst case scenario, if you have APO incompatible who is HLA incompatible, so you call it a double whammy. So you're a double hit. Normally, we don't do both together. In the past when we started, we used to do APO incompatible with a bit of HLA incompatibility. And of course, the immunosuppression you will get for the APO incompatibility is enough to cover the HLA incompatibility as well, because all of them will have plasma exchange, plasmapheresis, rituximab, IVIG, and so will be hidden hard as well with augmented immunosuppression. But again, APO incompatible is living transplantation. So, and most of these techniques I'm talking about is used for deceased transplantation when kidney offer from somewhere else, you don't know the donor. Because if you don't like this donor in terms of sensitization and APO incompatibility, we can ask for another donor. So try to avoid all these techniques altogether with the living transplant. But if you have to, yes, you have to go through this. But you're lucky enough, the paired exchange scheme now, which you find another compatible donor, and this donor will be compatible to another recipient, and will change the pair.
You mentioned the C1Q. And there was, many debates about the value of the C1q. What's your opinion? You are pro or against performing the C1q?
Okay.
I know you will detail this in part two.
Yeah.
But
shall I make it
give
more,
us a hint.
shall I make it more difficult? Actually, if you look at C1q as a checking complement activation early on at the early stage. And many things in our life, in our body, start but doesn't continue. So actually, we found a more correlation, and it's better to go for C4D and 3CD as well. So which downline the complement, more accurate than C1q. But C1q again measures complement fixing. Okay, does this mean that complement not fixing are not harmful? They are. They can cause damage to the graft, but the mechanism of damage is different, is long-term, like chronic antibody-mediated rejection or chronic kidney damage. So C1q, there's a lot of debate about it, and regarding the C3D and 3,4-D, which is supposed to be more accurate, still debating whether to do it or not. So every center does it differently. We stopped, as I mentioned, we don't do C1q because all these debates. Could be possible, but doesn't mean, that this patient will be safe.
We got a little bit pessimistic when you told us that the public epitope are very common. So what is how to tackle with these public epitopes, which are very common and of poor prognosis?
Actually, we should be aware of them. To be honest, no one can remember. We have hundreds and hundreds of HLAs and hundreds of crates, public epitopes. It's basically try to avoid this to this. It's like 1 for 1 and 1 for 2 is very simple mathematical. So we have to work around them rather than avoid them. They're already there.
Thank you. I think Dr. Ayman has some questions.
Okay. Yes, but I see Dr. Sharma have some comments. Okay, please, Dr. Sharma.
I would say that, I can ask Professor Halawa many times in a day. I am in much closer contact with him than perhaps anyone else. So, but I'm just using the opportunity to really pay tribute to, there's no better way of paying tribute to Dr. Hussain Shisha than my elder brother, Ahmed Halawa, speaking, doing such a wonderful lecture. Out of anything we may have done together over the last 6 years, today's lecture is going to make a permanent impact on my mind. Really, I did not know somebody can teach immunology so well. I myself did not know that. Really, I'm really stunned. Although I can ask many questions, I would leave it to others to really pose questions because it's a good opportunity for our younger colleagues. But if they don't have, maybe I can ask Ahmed to speak about, how has solid bead cross-match shortened the duration of cross-matching process in case you have got doubts about 1 or 2 antibodies in a patient who is being offered a cadaveric transplant, and the immunologists, rather than doing wet cross-match, they do solid bead cross-match. So if you can say something on that, but I'm really amazed, how Professor Halawa can really speaks with so much ease on this topic.
It looks like, AJ, you are, distracting me to discuss that part 2. Shall we leave it to part 2? Otherwise, I will, start doing part 2 straight away. Thank you for this compliment, AJ.
Okay, Dr. Ashraf Fouda, would you like to comment?
Thank you so much, Professor Ahmed, for discussing this hard topic in a simplified surgical presentation. Of course, the transplant team will be lucky if supported by a highly experienced immunologic lab staff who enabled the transplant team to proceed for transplantation of difficult cases. But in the reality, as you know, Professor Ahmed, our center in Mansoura, for example, is dealing with living-related donor and occasionally living unrelated donor in certain specific medical indications. So we are still applying BRA for immunologic risk stratification. Cross-match is complement-dependent cytotoxicity cross-match, and in some cases, flow cytometric cross-match. We are still concerned with the number of HLA mismatch, and epitope mismatch is not applied in our immunology lab. Of course, I agree with you that epitope matching is important because it helps in transplanting highly sensitized patients and is useful in retransplant candidates. Moreover, it could explain, as you said, the appearance of non-donor specific antibodies, although epitopes are donor specific. But I believe that, or I suggest that to be carried before minimization or withdrawal of immunosuppression is questionable. Your talk, actually, Professor Ahmed, could explain some of the poor immunologic and the clinical and the pathologic correlation in some of our cases. So thank you so much for your elegant presentation.
Yeah, thank you, my dear colleague, Professor Ashraf, for this compliment. But, you know, 2-2 mismatch is not a contraindication for transplantation in the face of strong immunosuppression and the advances in histopathology and the protocols. So again, one size does not fit all. It depends on, you know, the resources. It depends on your catchment population as well. You are treating Egyptian, different genetic makeup compared to what I'm talking about. So what applies to us not necessarily apply to you, but it could be guidance. What you apply it could not be applied to me, but it could be just a guidance. Just it's nice to know, you know, who's doing what and learn from experience. Thank you very much, Professor Ashraf.
Professor Ahmed, I have a comment about, as you know, that there is several studies showed that there are differences between the virtual cross-match and physical cross-match in the detection and evaluation of pre-existing antibodies prior to transplantation. However, recently, there are some studies showed that high-resolution epitope analysis was more conservative in identifying the DSAs with low-resolution serologic analysis. So in this setting of a negative flow CDC or negative flow, recipients with the DSA had similar short-term prognosis compared with those with DSA. So I think the presence of pre-existing DSA determined by virtual cross-match should not serve as an absolute contraindication for kidney transplantation. Would you agree?
Of course, yes, because you know, it's only one slide that presented about virtual cross-match because we can't present a talk about virtual cross-match. The problem with virtual cross-match, and I mentioned early on, it is imperfect science. So yes, virtual cross-match has a drawback, but you have to know the limitations. One of them is we could be penalizing. You could be penalizing recipients of being sensitized based on the virtual cross-match and not offering the kidney. However, their antibody level is below the cutoff and considered not to be a risk. So this is one. You know, in addition to when I mentioned the virtual cross-match as well, don't forget there's many HLA antigens are excluded from the virtual cross-match. DPs, the HLA-C, we have patients actually rejected because of HLA-C mismatch, but it was just 2 mismatches. DP, you will see in part 2, is not benign as well. Still, you can transplant, but still associated with risk. And the virtual cross-match will consider them negative. because DP was not timed in the first place. Is the whole idea is, Prof. Ayman, is just to know what you have and the limitation of everything. At least, not to be, expecting too much from a single test.
Okay, thank you. Do we have someone who should raise his hand to receive his comments or question?
Dr. Ayman.
Professor Gamal, please.
Thank you very much for the great opportunity. And Professor Halawa now is announcing a new branch in surgery, which is immunosurgery. I have two short.
I'm not a transplant surgeon. We call ourselves, we are transplant clinicians.
Yes, I have two short comments about the application of any of the mismatches. Do you apply the HLA and epitope matchmaker, which is a computer system fed by the all acceptable matches and mismatches and the risk of each mismatch, as well as the taboo mismatches, which gives you allowances of better outcome of certain mismatches? This is the first comment. Can you respond to this, please?
Yeah, we use HLA matchmaker. Yes, of course. Yeah, we do that.
So you apply all these by the matchmaker itself?
Yes.
Okay, that's fine. If you allow me to share one slide, I will show you something very strange. Would you allow me, Dr. Ayman, to share one slide? Share the screen for one slide?
Of course.
Yes. Allow me, please.
Okay, go ahead, Professor Gamal.
Can you see this slide, Dr. Ahmed, with me?
No, it's not clear.
No, it's not. No, it's not yet.
Can you see this slide?
No.
I will stop sharing again, and then أنا sharing. هستوب share وashare again.
Okay.
Can you see this one?
Yes, we can.
Yes.
Yeah. See in this slide, by chance I had this slide before your talk available. Those who have combined HLA desensitization and ABO desensitization together, which is the black boxes, after 5 years they had the best outcome compared to controls, to ABO alone or HLA alone. What is your comment about this slide?
Fine. Okay.
And this is very recent in 2019.
Okay. And this is most likely an American one?
Probably, yes. Yes.
There are recent data demonstrated that transplanting against positive cross-match, of course, after desensitization, is associated with chronic allograft damage, and 50% of these patients got transplant glomerulopathy and proteinuria. So based on this evidence, I can't quote it exactly, but I will get it for you because it's already published in the British Society of Transplantation guidelines. Transplanting and desensitization now in UK considered a clinical governance issue, a mistake. Why? Because we have the alternative, the pairs exchange scheme. And actually, Rob Higgins in Coventry, he retired. Actually, Coventry is a small city in the Midland. And he retired 2-3 years ago. He was a pioneer, an international pioneer in desensitization. And his data actually demonstrated that 5 years graft survival is good. But what about the 10 years graft survival? You go downhill.
Yeah.
Because of transplant glomerulopathy and proteinuria. Also, don't forget, Professor Gamal, that in order to achieve, I'm talking about HLA incompatible only. APO incompatible have the same good results as incompatible like compatible. Yeah. HLA incompatible is worse because particularly class 2, whatever you do, anti-class 2 antibodies, whatever they do, you cannot remove them because of the alpha and beta chain. They are polymorphic, the memory cells, they will bounce back. 2, what would you do in order to achieve successful transplant? I'm not talking about successful kidney, but I'm talking about live patients. Heavily immunosuppressed, CMV infection, all sorts of infection, PTLD. So I'm trading a functioning graft by giving infection and cancer. So if you look at 5 years, you have to give me 10 years. You have to give me as well the complications, because this is graft survival. What about the complication rate on this slide? Incidence of CMV infection. What about the incidence of PTLD? Always, I like to look at the whole picture rather than one figure. We used to do a lot of audits and present our work with different centers. When they talk about graft survival, fantastic, good, all right. What about incidence of CMV infection, PTLD, other associated complications? Have you seen patients before regretted of having a functional graft? I would like to remind you, because dialysis in many centers is quite good. I'm sure you know better than me in this. And when we offer a kidney, sometimes when we offer a kidney to our young patients who's working full time, he said, no, I'm happy with that. My lifestyle is adjusted. I do peritoneal dialysis at home, and we have hemodialysis as well at home. So some of them are in hemodialysis at home, and they refuse to come for transplant. And AG from Liverpool will give you the same comment. So graft survival is not enough without knowing the long term, without knowing complications associated with immunosuppression. When we started using Campath, it was good drug, much better than ATG. ATG needs central line, put a central line in and start giving ATG, short course, long course, whatever course is. But Campath, when it did come up initially with two subcutaneous doses, came up at intravenous. And then we changed it to subcutaneous because actually Liverpool, had mortality from severe anaphylaxis that died in the operating theater. And then we changed the protocol again to 1 dose rather than 2 doses. All our patients were not on CMV prophylaxis, got CMV. And CMV is a virus which can kill. And we have mortalities because of CMV. So the picture is not clear. We discourage transplanting, desensitization and transplanting against positive cross-match. And this is in particular for class 1. Class 2, different story. And this is actually the topic of part 2.
Okay, any further comments or questions? Please raise your hand. Turhani, would you like to comment before we have the last comment that I just received?
Dr. Ayman. Okay.
Dr. Faisal, please. Very happy to have you.
Professor, please.
Thank you. Thanks, Ahmed, for this excellent. It was very interesting and very simple for all of us. But again, as I saw from two of our colleagues, they were asking about because of the expense of the HLA and cross match and BRA, and our patients, most of our patients actually, they are poor, cannot offer this. What is the simple formula if you give it to someone, let us say from the family, that father to son, son to father, mother to son, or which one you are afraid? I remember in Scandinavia, one of the profs a long time back, he said that we don't do cross match. And we asked him how you are going to proceed without cross match. He said that we are in whole the country is from one descendants, and that's why we don't need cross match. And usually it is negative, so we don't have to do it. In our community, as you know, family and most of our patients are from living related. What is the simple formula and simple test which we can go ahead with it without going all the tests as everyone mentioned?
Thank you, Professor. Let's just think about it together, because, you correct me if I'm wrong. Of course, provided that to start with is APO compatible. Deal? Deal.
Okay.
No history of sensitization.
Okay.
No pregnancy, no abortion, no blood transfusion.
Yes. Okay.
Most likely the cross match will be negative.
Yes.
Fine. HLA, does it really matter? It does, but it's not that important with living related.
Yes.
Compared to cadaveric, because cadaveric, on top of that, you have a cold ischemia and warm ischemia time, which is damages the kidney and expose all the HLA to the immune system. So no sensitizing events, APO compatible. Would be good if donor and recipients both are men.
Okay.
Because they won't get pregnant. But are we discriminating against our wives, daughters, mothers?
We are not.
So, so you have to do cross match then. So, yeah, but you can say, I agree with you, we could be selective.
Okay.
Yeah, man to man, no blood transfusion, no sensitizing events, same family. We haven't talked about, minor HLA antigens, which could be contributing as well to the rejection, but this is another story. But the minor actually more common between female and male because of that, the sex difference.
Okay. Great. Thank you very much.
Thank you.
Okay. Any other questions or comments for Professor Halawa? Okay. Shall I go to the final comments that we received?
Can I just add one comment to what Professor Halawa mentioned?
Okay, go ahead.
Just very short. The patient, we have two patients who had reaction to Campath. One was, and both these were inadvertent infusion by IV, which was not really the plan, should have been by subcutaneous route. In one, the transplant had to be cancelled because patient developed hypotension and the patient recovered later on. The other patient had dual transplant and she died in ITU 3-4 days later. And that was actually, although one may think it is an anaphylaxis, but we call it anaphylactoid, like giving impression as if it is an anaphylaxis. It is basically, as you know, because of lysis of lymphocytes. So because of that, which looks like anaphylaxis, but it is not. So I thought I'll just add to that. In over 60 years, we do not give Campath. We do not give 2 doses. We just give 1 dose of Campath. Thank you.
I mean, yeah, AJ, based on your terrible experience, we changed our practice, because if you see, Campath is licensed to be given intravenous, but we don't like, to have patients suffer from hypotension means not transplantable, or ended up in the ITU and dies later. Also, we changed the practice as well. This is actually based on leads because we discovered they were ahead of us and they start using 1 dose with good results. So we use 1 dose rather than 2 doses. So we try to, as much as we can, to minimize immunosuppression because, we are poisoning these patients and give them infection and malignancy. However, Campath still not proven to be incriminated with cancer, but definitely infection.
دكتور احمد بليز اتفضل دكتور احمد عقل.
طيب شكرا دكتور ايمن. I would like to thank everyone, all our leaders, and I think this is the first time after Professor Hussein, and it looks wonderful with Professor Halawa. Just came to my mind from my experience in Oxford in 2002 and 4 as regards the discussion of the pure descent of populations and the immunity reaction. So at that time, they started to, during my training, to do MLR, the mixed lymphocyte reaction. And I remember that when I worked with samples from Oxford, I nearly saw nothing. When I mix different populations, we got to have the leukocytic leukocytes from the blood bank and do the MLRs. I have nothing, and it was very frustrating until I got my samples from Mansoura, from our patients, the transplant patients, and the all expectations, it was very low because we cannot see a very good MLR in healthy population. So what is expected from immune suppressed transplant recipients? But when I did the MLR, we saw a very forcible reactions against the donor from our recipients, and it was amazing that everyone was looking for it, and even it make me to allow me to complete my thesis and in the study of regulatory T cells, especially when we removed regulatory T cells from part of their samples. We saw a forcible reaction. So I think the discussion about the different populations is really true, and we are seeing different scenarios in Egypt. And I'm wondering if Professor Halawa is seeing a lot of rejections in UK nowadays. I don't know if this is the same like in the beginning of 2000s, or it is more because of the more nationalities came to UK. And thank you.
You'll be surprised because the rejection rate is, we're talking about the rejection rate in hospital rejection rate. So before patient goes home is around 15% and kept stable, 10 to 15%, kept stable over years and years and years and years. But of course, immunosuppression protocol, if you look at immunosuppression, we started with Sandimmune and big doses of azathioprine and massive doses of steroids. And even before that, total body irradiation was cut insanity, quite mad immunosuppression, buckets of immunosuppression. Now it's tailing down to be more specific. Don't forget, we'll start to know a bit more about the immunosuppression and the pathogenesis of rejection. But rejection rate stayed the same, hasn't changed. in spite of the changing in the immunosuppression. But what's noticeable, infection rate is increasing. CMV, BK, all other viruses infection, COVIDs, we shouldn't forget it. So all sorts of infections is increasing, but this is actually can't tell us that our immunosuppression is still aggressive. On the contrary, we're taking more highly sensitized patients, badly matched kidneys. So there is no win situation here, basically. But at the end of the day, graft function, graft survival, patient survival, what is really matter.
Okay, so thank you very much, Professor Halawa, for this very, very elegant and stimulating talk, and allow me to end up this session with this sensational comment.
Okay, thank you very much.
What about ablet matching? When we do tissue type, we concentrate on the allele of the HLA type, not HLA. If we say HLA, the surface that contains amino acids, and the unit, small unit of the HLA is ablet or epitope. So it is gathering of some amino acids that may be antigenic or immunogenic.
تعالى كده شوف يا محمد. Excuse me, the audio is functioning. يعني, did you hear Dr. Hussein, or were there a problem?
It was very faint.
Very faint. Okay, so it's not. It was not audible, huh?
Hardly audible.
Hardly audible. Okay. Okay. مش سامع يا دكتور اشرف.
They have low ablet mismatch for those who have high mismatch. So, depending upon the traditional method, it will not reflect reality. So another study showing the ablet mismatch mode, and the occurrence will be the same. And as you see here, we have ablet mismatch for HLA, B, C, DRB. up to A1, B1, and others. If you look at the bold one, DQ, you will find it correlates with de novo OSA, any rejection, graft function, and graft failure. So antibody verified ablet mismatches in HLA-DQ confer substantial risk for de novo OSA, graft rejection, graft function, and graft failure to be put in mind. This is why the editor of this article put this under the title Renaissance. Renaissance means progress. This is how we are going to evaluate. And if we apply the molecular pathway, it will improve and refine the risk evaluation. Very much. Hoping all the best for all my professors and colleagues and all Arab world and all who will hear the video on the tube. Thank you and goodbye. Targeting the ablet matching.
Okay, I think I thought that we could not leave this meeting without this comment. I think Professor Hussein will be always with us in the deep of our hearts. So I think by his voice and his message, we can end this meeting. Thank you very much, Professor Halawa, for being with us and for this very, very elegant presentation. And we are looking forward for the interesting part 2 of this lecture. I think it will be more applied on cases and case scenarios. Thank you very much for Professor Hani, Professor Ashraf, Professor Faisal, Professor Gamal, for Professor Al, for all the audience, and we hope that we can carry on and continue on this the big mission started by our beloved Professor Hussein. Thank you very much. Thank you all. Thank you.
Thank you very much.
Thank you.
Looking forward to see you.
Thank you.